I have a story about two women today. First woman's name is Susan. She's in her 70s, born and raised in New York, and she was a successful lawyer at the Wall Street for many years. One day, she was diagnosed with breast cancer. She had double mastectomy, which is removing both of her breasts. And she really didn't like the idea of getting a surgery to begin with, because after the surgery now, she didn't feel like a woman. She didn't feel like a wife, and she didn't feel like a mother. But she really tried to convince herself that she had cancer, and she got treated, and that was all good. So that's Susan. Second woman's name is Amy. Amy is very much like Susan in that she's also in her 70s, a New York native. She's a dermatologist. And one day she was also diagnosed with breast cancer. But she didn't get surgery, she got hormone therapy. Because her doctor said that the hormone therapy would slow the growth of her cancer. And Amy was comfortable with that idea. So Amy and Susan are actually friends. And one day, Amy shares her story to Susan. And this really changes the way Susan thought about herself. Because Susan didn't know about hormone therapy. She thought that surgery was her only option. So Susan starts thinking to herself, did I miss something? Maybe if I had only known, I might not have the body that I have right now. So what was really hard, more difficult for Susan was more than being diagnosed with breast cancer, more than going through the surgery, was to know that she had options. And so later, Susan became clinically depressed, and she said, I wish I had known. It's a difficult story. So how did this happen? How is it that two very similar women with high levels of education, they even went to the same hospital, but their endpoints were very different? How did that happen? So I first thought that it's probably because of Amy's doctor, that maybe the doctor was more compassionate, maybe more intelligent, knew Amy better. But no, they both had equally qualified physicians who really cared about their patients, and it still happened. So it turns out that there's a pattern, there's a reason why things work the way it did for Susan, and people like Susan. And what happened to Susan can really happen to anyone here today. And I'm really excited to share about a solution, which is really simple, and it's something that anyone can do. So before I share that with you, so this is what Susan said, I wish I had known. But I'm sure that this is something relatable to everyone. We share this commonly. And if you do a quick search online, people write about this, share about this all the time, because there's this idea that we try to make the right decisions every day, and we definitely don't want to make the wrong decision on something that's literally life-changing, like Susan and her surgery. And we definitely don't want that to happen, just because the difference was whether you knew it or you didn't. So how did this happen to Susan? Why didn't she know? Well, assumptions actually play a very key role in this. Let's say that we are all physicians, and let's say that our friends are saying, oh, you work as a physician, that means your work life must be like Grey's Anatomy. But you're saying, okay, there's paperwork, paying back medical school debt, clicking, clicking, clicking. So what you think about yourself might not be what other people think about yourself. And there's a gap. And this is what's exactly happening to the patients. So 71% of the physicians thought that patients with breast cancer would want to keep their breasts, and it's important to them. But actually, when you ask the patients, only 7% of the patients thought that keeping their breasts is important. That's a striking difference, 71 to 7%. And it's a gap of assumption. So there's a disconnect between what patients thought that they want and what their physicians thought that they want, which is really scary. But what we assume is happening, or what we really ideally want, is this: that all of the physicians to know what their patient wants, and all the patients to know what they want. So we want this connection, which is what we really want. But a review looking at over 30 studies see that this is not really happening in the clinics just yet. But it's really interesting, right? Because we have fabulous physician assistants, intelligent nurses, and compassionate physicians who really want the best for their patients. But we're saying that that's not happening. And sometimes in medicine, the decisions are really simple. Like if you have bacterial pneumonia, you should take antibiotics. But there are other situations in medicine where there are multiple roughly equivalent choices. And each option gives you a different flavor of benefits and risks. And in these situations, when the doctors don't know what their patients want, the doctors might say, okay, I think we should go with this treatment. And this will take you to where you want to be. But this end point might not be where the patient wants to be, like what we just found out. And when that happens, when the patients are not well informed, the patients also start making assumptions. Like, oh, this treatment will prevent me from having future episodes, or there won't be any complications, and this will fix everything, when that might not be true. So there's assumptions from both sides, from the physicians and from the patients, and there's a disconnect, which is why this I wish I had known is happening when the unexpected happens. So our point, so my colleague and I are very interested in this, and our point is that we need to stop assuming, and we need to start training these providers with shared decision making. Because we know that when patients are well informed, they make different decisions. So for example, a study said that when the patients were well informed, 40% of the patients, when the patients were well informed about the risks of sexual dysfunction in surgery for benign prostate disease, 40% less patients wanted surgery. They said they don't want the surgery anymore. And it's exactly these 40% of the patients who were protected from I wish I had known, because now they knew. And this is not only for breast cancer. These data exist for many other diseases. So our team made a web program so that anyone can now have access to shared decision-making program, training program. And it's really exciting because these contents were made by top professors at Dartmouth who lead this field in shared decision-making. And what's really exciting is that, yes, the students go through basic lectures and quizzes, but there's this added feature of online interviews with standardized patient coaches. And so the students would practice shared decision-making online, and then the coaches, at the very end of the session, would grade their students on each of the categories, on each of the behaviors that the students are supposed to perform to make it into really great shared decision-making. So I want everybody here today to leave with at least one of the secret techniques, and it's called team talk. So team talk is this idea that the providers are supposed to say, not even think about it, but just actually verbalize, okay, we are going to decide this together. Let's do this together. So that might sound, oh, that's really nice, that's really warm and fluffy, but actually data support that what really most influences the patients to get engaged in the decision-making is their provider's enthusiasm and attitude to get engaged in shared decision-making. Which is really cool, because just think that just by saying, hey, let's do this together, can change somebody's life. Imagine what would have happened to Susan if she was told, Susan, let's do this together. Let's find what best works for you. That alone would have prevented her from I wish I had known, and that would have protected her from dangers of assumptions. So I'd like to make a point that was highlighted in this morning talk, but communication is often assumed to be this warm and fluffy, fuzzy field. But I like to challenge that, because evidence-based communication is a practical tool. We don't all need to be genius communicators like Dr. Larry Chu. We don't always have years of experience, but even beginners can become A+ communicators just by going through a checklist of behaviors, and that's exactly what we found. We invited nursing students, physician assistant students, and medical students to join our program, and we found two things. So first of all, is that just going through lectures is really not enough. They need to actually practice. Their scores improved after going through the sessions with the coaches. And two, and more importantly, is that these were students who knew nothing about communication, but just after going through a very short program like this, they became A+ communicators by grading system. So it's really important to know that assumptions really don't need to happen, and we don't need I wish I had knowns, because just with a checklist of behaviors, we can become great communicators. So really, I wish I had knowns can change to a confident I know. So I'm really happy to be able to talk to you about this. And I know that we have a great audience here. We all care about this, and that educations matter, and patients matter, and the improvement from beginners to A+ communicators when done by the power of education. And it's not only for the patients too, the providers. So a lot of our students said, I'm really glad that we got to know this. That was really useful, that was really empowering. Some of the doctors that I work with, they said, you know, I wish I had known about this when I was a medical student. So it's because the providers really care that they're not unknowingly harming their patients. So what I want to say is my hope is that we all start finding what best works for everybody that we care about. And we can really do this together. Thank you. Right, I should have my mic with me. Yes. Right. So just to get a little technical, so integrating new material in medical school curriculum is actually really difficult because it's really tight. So what we wanted to make sure is that by doing online program, anyone can have access in their free time. So this currently is not integrated in the medical curriculum, but the nursing school that we're working with, they're trying to implement this in their curriculum, and we're trying to integrate this in residency programs at Dartmouth too. I think that's another challenge, but this is one of the reasons that I'm doing a talk, so that more people can start talking about this and then start really learning the idea of shared decision making as a very important communication tool. We also don't have the time, but if we can understand that this is a skill, it's really easy to learn too. I mean, these are, again, really beginner students, and it was only 2 hours of work. So I think if we can fit 2 hours in somebody's time, in their whole career, I think it's something that's doable. Yes? Right. So the question is, what about postgraduate learning? So that's another challenge that we have, because it might be easier to influence the undergraduate medical students now than people who have been already practicing for so many years. And, I'm not sure how to answer that question, but I think if people in the junior stage start learning about this, I think there's something that the attendings and people who have been working can learn from younger students as well. Mm-hmm. Right. Right. So right now we're currently focusing on the undergraduates and the residencies and the fellows, but above that we're not so sure yet. And one of the reasons why we applied online was that the millennials are more familiar with working with online technology as well. So that's a different challenge that maybe we can talk about. Yes. Yes. Mm-hmm. Thank you. That was a great point. Yes. Yes. Mm-hmm. Yes. Mm-hmm. I can't really say that with a solid data. And I talked with a lot of students who were involved, and I didn't see a significant difference within our group. And it might be because we asked the students to participate in the program, and those students were already interested in doing our program, so it might be a selection bias. But that would be something interesting to look for, yeah.